Hi, Sonia. Thank you very much for joining us today. And I know you're going to sort of introduce yourself very briefly, and then you're going to start asking me some questions. We've already had some come in, so we'll start with those for the moment.
Hi, Katie. Hi, everyone. As Katie mentioned, I'm Sonia. I've newly joined the team of nurses here at Breast Cancer Now, and it's really lovely to be here this evening. So, as Katie mentioned, there are a few questions that have already been sent in, so we'll start with those. The first question, Katie, is from Elle, and she has asked that she has had a double mastectomy, and has been told, I assume, by her treatment team to get in touch if she has any changes. And a very good question: how do I know what's not right?
Now, that is a really good question. So, if you've had a double mastectomy, Elle, and I'm sure as you're aware, that means that you've most of your breast tissue has gone. So that's about 99% of your breast tissue has gone. So you won't have any breast as such to examine. But we would always say to examine your scar lines and to check along those lines and check if there's anything different along your scar lines. So any rashes, any lumps or bumps, any changes to the skin, and also to examine up to your collarbone and underneath your armpits as well, because you've got breast tissue and lymph nodes there. So if you were to notice anything that was different in those situations, then it's always a good idea to get in touch with your team, your breast care nurse or your treatment team, and express any concerns that you might have. We also say to be aware of your body as a whole. So if you were to notice any persistent changes, anything that was different anywhere in your body, but things that you might be looking out for would be things like a persistent cough that doesn't go away, pain, particularly back or hip pain, that sort of thing, unexplained weight loss, fatigue, headaches, dizziness. All of these things can have multiple causes, and I want to emphasise that as well, because it's very natural once you've had a treatment for breast cancer to be very worried about cancer coming back. So we would say to be aware of your body, and it's really natural to be worried and to ask for things to be checked out, and that's what your treatment team is there for. So if there is something that is persistent, that isn't getting better, that isn't going away, and you can't think of a cause for it. So, for example, if you've got backache but you know that you've been gardening, that's more than likely the cause of it. But if there's something that you can't think why that's happening, do get in touch with your treatment team. So, I hope that covers that. Was there anything else that you think I should add
No, and
in there?
I think you answered that. And it's the key word that you used there was persist, and I think that's really important. That if any of the symptoms persist, to notify your treatment team, and
Yeah.
sort of familiarizing yourself with the new normal, and just being aware, as you said.
Which can be really difficult, can't it?
Yeah,
Knowing sort of
absolutely.
what is normal for you now, because everything will change and your trust in your body will have changed as well. So probably what you may have just brushed off in the
Mhm.
past, you will be much more aware of these days, and your treatment team will also be aware of that too. So we often hear people on the helpline saying they don't want to bother their treatment team, they're so
Mhm.
busy, but that's exactly what they're there for.
Absolutely. Yeah.
So,
Yeah. So, next question, which kind of links in to what Elle had asked, was from Helen, and she has asked, "Is a double mastectomy better than a lumpectomy if money is no object?"
okay, so not really, no, Helen. So, and again, that is something that we get asked quite a lot. So we know that if, unless you've got sort of a genetic a gene like a BRCA gene or a PALB2 gene or something like that, that means that you're at higher risk of developing breast cancer. Double mastectomies are not usually recommended. And that's because there's no survival benefit to removing a healthy breast. And we know that if you have a lumpectomy followed by radiotherapy, that is as safe and as good a treatment option as having a mastectomy. So most people wouldn't choose to have most surgeons wouldn't want to be operating on a healthy breast. There are some exceptions to that if there's If it's for symmetrical reasons or psychological reasons, sometimes that can be considered, but that's something you'd have to have a conversation with your treatment team for. But they certainly wouldn't do that to reduce the risk of the cancer coming back unless you had a gene alteration. So even in the private setting, I think that's what you would find, because we know that actually cancer can be treated really well with just removing that area with a good margin and radiotherapy afterwards.
And I think it's just important to understand, as you said, that the evidence points towards having conservative surgery with radiotherapy is just as effective. But
Yeah.
you know, as you said, Katie, it's quite a commonly asked question, and I think it's important to go back to your treatment team, to your breast care nurses, to understand, you know, your individual risk in terms of the risk of recurrence, and I guess considering the sort of the psychological impact that having a bilateral or double mastectomy can have. But yeah.
Absolutely, and that can have quite a significant psychological impact on people. It can affect your body image. It can affect all sorts of things. So yeah, it's not an inconsiderable thing to think about. So yeah, it's something that if you were thinking about it for if it wasn't for reducing your risk, then certainly have a conversation with your treatment team. But it's not something that's routinely done.
Absolutely. Yeah, thank you. Okay, so another question from Andrea. So she has asked, what's the best way to manage a tibia lesion, avoiding a yearly mammogram?
Okay. So, for those of you that aren't aware, an atypical lesion or atypical area in the breast is a benign condition. So, it's when the cells have started to change, but they're not cancerous. That is usually managed by removing that area. So, normally as a vacuum assisted biopsy or a surgical excision biopsy, as a day case procedure, often, mostly. So, it's just usually removed because although it's a benign condition, for some people and certain types of atypia can increase the risk of breast cancer. Not for everybody, but for some people it can. So that's why it's routinely removed. After that, if it has been removed, follow-up will vary according to the type of atypical lesion it was, and whether it was completely removed with good margins, and depending on the team as well. So some people would have annual mammograms following that for a certain period of time, other people wouldn't. So there isn't really a set sort of protocol for that. It's something that you'd have to discuss with your team to see. But as I said, usually for an atypical lesion that would be removed with a little operation, which is normally a day case procedure, and you would be home that evening.
Another question from Sneha. Again, I think that this is a commonly asked question, is that she's asked to tell us more about hormonal positive breast cancer with HER2 negative. I'm assuming with her HER2 negative.
Okay, and that's a really good question, because the pathology of breast cancers can be very confusing, particularly if it's not something that you're used to talking about. And I think sometimes the breast teams are so used to discussing pathology that they don't always explain it in a way that is easy to understand. So when we're talking about things like receptors, so estrogen positive, hormonal positive cancers, HER2 positive or HER2 negative cancers, what we're actually talking about are the receptors on the cells. So you have three receptors that you're looking at, really. So the estrogen, the progesterone, and the HER2. And depending on whether they're positive or negative would then sort of decide what sort of treatment would work for you, because those receptors are what makes the cancers grow in a way. So if it's hormone positive, it means that it would respond to hormones. So any cancers that are hormone positive, they can be treated with hormone therapy. So that's often tamoxifen or an anastrozole or letrozole, an aromatase inhibitor. If it's hormone negative, then it wouldn't respond to that treatment, so that wouldn't be required. And similarly with HER2, if it's a HER2 positive cancer, then we know that that would respond well to a drug called Herceptin, which is routinely given with chemotherapy. If it's HER2 negative, then that treatment wouldn't be of benefit, so you wouldn't need the Herceptin. However, you may require chemotherapy, because they don't just look at that, they look at lots of different factors when they're deciding on your treatment plan. But those receptors will determine whether or not hormone therapy or trastuzumab Herceptin would be a treatment that would be of benefit for you.
I think that's what's the great thing about the treatment available now for breast cancer. It's very much so tailorized to the individual and the particular um, features of that breast cancer. And so there's a lot available online, isn't there? And quite often, I think when you do have a breast cancer diagnosis and you see that somebody else may have had a particular treatment and you haven't been offered it or it hasn't been discussed, it may just be that the different features and what's responsive to your breast cancer and what is to other.
Absolutely. It's much more personalised now than it was 20 years ago, for example. And there were lots of so many different types of treatments. And they've often given in different orders as well. And that can be really confusing because you might say, well, my next door neighbour was diagnosed with breast cancer and they didn't have the same treatment as me at all. But that will be because their treatment will have responded to different things and it will have had different features, as you say.
Yeah.
I'm just looking here for a moment, Sonia. There are a couple of questions that have come in. So I just wonder if we should maybe go to some of those first.
Yeah, let's go for it. So hi Samantha, she has asked, lymph nodes that itch, is that concerning?
So Samantha, thank you for writing in. So you haven't said whether or not you've had surgery or any treatment or a breast cancer diagnosis before. So itchiness, if it's a new change to your armpit and there's something different going on there, we would always say get that checked out. If there's any rashes, if there's anything like that it could be multiple causes and we don't know what would be causing that, but it could be skin reactions, it could be all sorts of things. But anything, as I was saying earlier, anything that's new, if it's something that's changed for you, then I would always recommend that you go and get that checked out. If you're not under the team of the breast treatment team at the moment, then go to your GP. If you are under the breast team, then go back to your breast care nurse and just ask them about that and they can assess you.
Yeah, absolutely. And Lynn has asked, hi Lynn, she has asked, she had a mastectomy and a full lymph node removal. She keeps getting the fluid build up with about 400 to 500 mils being drained for the last 2 weeks. When will my body start to absorb it?
Oh, Lynn, that's tough, isn't it? So that is a really common thing that can happen after surgery, particularly mastectomy surgery. What you're experiencing there is something called a seroma. And a seroma is serous fluid that collects as part of the healing process. So it's a very natural thing that's happening. It's part of the healing process. The fluid collects in that cavity. And a little bit of fluid the body will absorb on its own. If you've got 400, 500 mils of fluid, that can be really uncomfortable and that can cause quite a lot of tightness, which is why I suspect they're aspirating or draining that for you at the moment. Generally speaking, if you've got that amount of fluid building up, it will start to reduce, but you may need to have it sort of drained off for a few weeks until it does less than sort of if you have it done at every week. I wouldn't do it too frequently because the more often you do it, the more likely that fluid is to build back up again. But if you to have it done weekly, you'll find that eventually it will reduce, and it's really difficult to say how long that will last for you. But normally, I'd say it's a few weeks before the fluid completely absorbs, but eventually it will, and you won't need to be aspirated. You might still have some fluid there, but eventually that will absorb. And normally that's, I'd say, about 6 weeks or so, would you say? But there is no set rule for that. Everybody is different.
Absolutely, and it's as you said. I mean, especially having had a mastectomy and a full lymph node clearance, it's very common, and so it's not unusual. It's obviously a nuisance, but hopefully with time, that's something that should settle.
Yeah.
So let's go to another question. Leona has said, I have had 6 months of chemotherapy and now on 2 weeks of 4 of radiotherapy. She has started to get really bad joint pains, especially in the hands and back. Is this likely due to radiotherapy, daily visits, or delayed side effects of chemotherapy?
Okay, and that's a really good question, Leona. I'm sorry you're experiencing that because that sounds really quite miserable. So joint pain wouldn't really be a side effect of radiotherapy. It can be a delayed side effect of chemotherapy. It can also be a really common side effect with hormone therapy. And I don't know, you haven't mentioned whether you're on that or not, but hormone therapy can very often cause joint pains. But if you've had the chemotherapy, a lot of people do suffer from what's called myalgia or aches and pains from chemotherapy as well. So it may well be that it's that. It could be the position that you're lying in when you're having the radiotherapy. That could maybe affect as well, if it's on your back. If it's really persistent and you're really struggling with it, I would suggest going back to your treatment team and just letting them know so they can examine you and just see whether maybe you need some physiotherapy, whether they want to do any other sort of assessments of you for that. But it's most likely to be, I would say, a side effect of treatment. What would you say, Sonia?
Yeah, no, I completely agree. It sounds like it's more so again with the chemotherapy as opposed to the radiotherapy that you've mentioned. So Leona, I think if it's obviously troubling you and it's quite bothersome, then definitely do mention it to your treatment team because they can sort of look into it. Further investigations if need be, or it could just be referring you for something like complementary therapies that could help.
Yeah,
But yeah, just
absolutely.
keep an eye on it and see how you get on, I would say.
Yeah, and sometimes simple analgesia can be quite effective as well if it's
Absolutely,
something
yeah.
that's
Yeah.
yeah. So,
Okay, so let's have a look at a couple of other questions. So Julie has asked a very good question. So what can I take for hot flushes and aching joints? She has an estrogen receptor positive breast cancer, has had a lumpectomy and radiation. What is the alternative to letrozole, please?
Okay, Julie. Oh, that is a very common question, as you say, Sonia, and it's something that a lot of people talk to us about on our helpline and also on our moving forward courses. The side effects of the hormone therapy, such as letrozole, they can cause lots of menopausal side effects, such as hot flushes,
Mhm.
vaginal dryness, mood changes, and aching joints as well. So if you are struggling with that, there are things that can be done. So a lot of people do find that for the hot flush, we've got lots of information on our website. So it is worth having a look at that as well, managing menopausal symptoms. If you put that into the search box, you will find a lot of information on our website about different things that you can do to help manage that. And they range with those treatments. So for things like hot flushes, some people find that wearing natural fibres, having a fan, being really hydrated, always having a glass of water to hand, those sorts of things can be effective and they don't need anything further. Other people find complementary therapies that we've already mentioned a little bit can be really helpful, particularly acupuncture, Reiki, those sorts of things can also help. We know that with anxiety, if you're getting hot flushes, that can also come hand in hand with anxiety, and that's sort of a vicious circle because then you're going round and round. You're getting more anxious, the flushes are getting worse, and then you get even more anxious. So sometimes people find that actually some talking therapies can be helpful as well for managing those things.
Mm.
With aching joints, again, so the complementary therapies can help, but also things like doing some weight bearing exercises can actually help, or some stretching exercises. So things like Pilates and yoga can also be quite helpful. I appreciate that's not always what you feel like doing when you're in discomfort, and it's building up to those things really gradually. If you're really, really struggling, there are medications as well that sometimes doctors will prescribe to help with the hot flushes. And there are things, depending on how long you've been on the letrozole, sometimes you find that for the first few weeks, those side effects are really quite intense and they can be really difficult to manage. But if you persist, and you can sort of do that, and not everybody can, you may find that they settle down after 6 to 12 weeks and they do improve. And if you consider that a lot of people are taking these drugs for quite a long time, if you can get through those initial few weeks, you may find that you do actually manage to manage those side effects a lot better and they do improve. If they're
Absolutely.
not improving, then please do go back to your treatment team because they can talk to you about alternatives, and there are alternatives to letrozole. There are alternative brands within letrozole,
Hmm.
and there's also alternative aromatase inhibitors, and there's tamoxifen as well. And on the labelling, they all say the same side effects, but we know that a lot of people get on better with one than rather than the other. So it's sometimes a question of trial and error to find out which one suits you best. So please do go back to your treatment team and talk to them.
Yeah, yeah, exactly. And I was just going to add, it just, as you said, depends on how long you've been taking it. And I think usually with a lot of breast teams, the sort of the benchmark is about 12 weeks. And so if you can, as you said, try to persist and see how you get on. But you can always, as Katie mentioned, try changing the brand or try changing the time at which you're taking the letrozole. Again, some women
Absolutely, yeah.
have found that helpful. But yeah, if it's getting to a point where it's getting increasingly worse, then absolutely speak to your treatment team, because there are always things that can be done.
Yeah.
And ultimately, it's kind of taking into consideration sort of your quality of life, whilst taking it, because as you said, you're on it for a long period of time, 5 years, and that's quite important.
Absolutely, quality of life is important. So going back to your treatment team and asking what the benefit is, and the risks
Exactly.
and the benefits, and making that
Yeah.
informed decision as well. Yeah.
Yes. Yeah. So again, similarly, Teresa has asked, I'm on anastrozole for another 5 years, but my yearly mammogram has stopped from last year. Is there any way I can carry on having them yearly because I've got a high rate of recurrence?
Okay, Teresa. And that's a really common question as well, isn't it? That we get a lot of people find when they get to the end of that 5 years of follow up, a lot of people feel like their safety blanket has gone.
Yeah.
They feel quite understandably anxious. But actually, the research has said that shown that the most important time to have those mammograms is in the first 5 years, and after that, the NHS certainly wouldn't be providing yearly mammograms after that, and you would go back into the screening program, so it would be every 3 years at that point. And that's because we know that the risk of recurrence is higher at the beginning, so that's why you would have those mammograms yearly for the first 5 years. But it is not unusual to feel nervous about that, and I suppose it's just about having that confidence to examine yourself
Yeah.
and to know what to look out for. And if you do notice anything that's changed, anything that's different for you, is to report it. So
Yeah.
it's getting used to what your new normal is, really, and knowing how to examine yourself, and where to check, and doing that on a regular basis, so you
Yeah.
know what's normal for you now. And then you'll notice anything that's different, and going back to your team and not hesitating to do that if you're worried about anything.
Yeah, absolutely, and it's as you said, it's completely understandable where you kind of have that safety blanket for the next 5 years, but it's not to say that the door is closed. It's if you notice any changes, any concerns that you have, you can absolutely go to your GP and be then referred back to your breast team.
Absolutely,
So there's
yeah,
always a possibility.
yeah.
So let's go on. Let's have a look. Joel has asked, can I choose to have surgery to remove the original tumour despite it already being spread to my lungs?
Okay. And that's a good question, Joe. So that very much would depend on a number of things, really. So it depends on, I think you said that there were small nodules in your lungs, and it depends what treatment you're having for that and if the cancer is responding. Often people tend to treat, if the cancer has gone somewhere else, they will treat that first and see how that's responding. If it's responding well, there might be an argument to go back to your oncologist and ask them to refer you back to the surgeons to have that discussion, and see. It's not routinely done, but that doesn't mean to say that it can't be done. And in some cases, it can be removed, if it's a small area in your lungs that's responded well to treatment.
So Jane has asked, hi Jane, she has said, is sharp stabbing pain under rib and to side common after radiotherapy?
Okay. So sometimes you can have increased sensitivity around the rib area and where you've been treated. It depends where you've been treated, but often people can find that particularly if you've had a mastectomy and you've got less breast tissue there, that your ribs might be a little bit more tender following radiotherapy. You don't say how long after you've had the radiotherapy. So you can have some changes that can last for a few weeks or months. Longer term pain like that, if that's something that's persistent, then certainly I would be talking to your team again or going back to your GP to get that checked out, just to check that there's nothing else going on there. But it can be a post radiotherapy sensation, certainly.
Colleen has asked, so she was diagnosed quite young, at 32, with a grade 3 breast cancer and had a bilateral mastectomy, what we were discussing earlier. She's had the oncotype, and she's currently waiting for the results. Is she likely to get a higher score?
Well, that's difficult to know, Colleen. So you don't mention whether or not you've had any lymph nodes involved there. And what the oncotype is doing is it's looking at the biology of your individual cancer. So until we get that score back, we can't really predict what it's going to say, because what it does is it looks at your cancer particularly. It will give you that recurrent score, and that recurrent score will then indicate whether or not you're more likely to benefit from chemotherapy or not. So for younger women with a higher grade cancer, sometimes traditionally they would be given chemotherapy if they were node positive. The oncotype is there now to sometimes it can de-escalate that. So if it comes back and you've got a lower score, it might be that you don't need to have that. But I think that would be a consultation to have with your oncologist and a question to ask them when the score comes back, and they can explain to you what that score means for you, and what they would recommend in those circumstances. So I'm sorry, I can't be more sort of exact with that, but I think until we know the score and we know a little bit more about the biology of your cancer, we can't really tell you what that score is going to be.
So there's quite a few questions coming in about pain. So Nikesh has asked, his wife is on Keytruda for 6 months now, but struggling with hip and knee pain. It's even very difficult for her to walk. Is this normal?
Okay, so Nikesh, I think that's something your wife would need to go back to her treatment team and talk to them about, because if she's really struggling and it's really affecting her quality of life and making it difficult to walk, I think that's something that needs to be addressed. So I would really strongly advise her to go back and talk to her treatment team about that and see what they say with that.
Yeah,
So that sounds like she's having a really difficult time.
And similarly, so Sarah has asked, so she was diagnosed last May with an estrogen positive and HER2 positive later in after surgery. She went on to have a full lymph clearance and lumpectomy, had chemotherapy, surgery, 3 weeks of radiotherapy. She's now on Phesgo every 3 weeks, ovarian suppression and letrozole. Yesterday she had zoledronic acid and has been in pain and in bed all day. Will this get easier? I have to have it every 6 months.
Oh, Sarah, that sounds really tough. You've been through a lot, haven't you? Um, um, Zoledronic acid can make you feel quite grotty for a day or two after you've had that infusion. Generally speaking, that improves, though. It is a short-term thing. So people sometimes report that for a day or two that they might feel fluey, they can be in bed with pain, they can feel really quite rotten for those 2 days, but then they recover from that. If it goes on for any longer than that, certainly I think you need to talk to your team about it, because you're right, if you're having that every 6 months, you don't want to be dreading that happening each time. It is early days, you only had it yesterday, so I'm hopeful that over the weekend you will start to feel better. But if you don't, then I think you need to get that checked out, talk to them as well. But it sounds like you've been through an awful lot, and hopefully now things will start to get a little bit easier for you. And if you do want to sort of get in touch and phone our helpline and talk to us, and that's for anybody that's put in questions here, if you feel that it would be helpful to talk to the nurses, we do have a helpline. It's open again at 9 o'clock tomorrow morning, and we're more than happy to talk through anything, any concerns that you have sort of on the phone. So, and that number, just so you're aware, is 0808 800 6000.
Yeah, hope you feel better soon, Sarah.
Yeah.
Okay, so a few other questions again, with relation to bone pain. Sharon has asked, is bone pain a common side effect with chemotherapy? I've actually had to walk about the garden with my girl at 3 in the morning to try to ease it off.
Oh dear. It can be. It can be something that happens with chemotherapy. I don't know what chemotherapy you're taking, and some it can be worse for them with others. So it depends which one you're on, really. Sometimes, usually, you would have 3 or 4 cycles of one, and then switch to a different one, which hopefully the side effect profile will be a little bit different for that. If it is causing you a lot of discomfort, talking to your treatment team, phoning up. You should be, if you're on chemotherapy, phoning up the hotline number that you have to talk to them about that, because they may say you'll take some analgesia. Taking analgesia, you need to make sure that that's okay, and they might suggest that you check your temperature first as well, because some analgesics can mask a temperature and mask a sign of infection. But if you're really struggling, certainly do talk to your team and phone that hotline and talk to them about how you're getting on.
And the same with June. She has asked. She has had her second chemotherapy with 4 cycles to go. Both times she has had stomach cramps, constipation, and very small amounts of runs together. The hospital did give her Laxido. Is there anything I can do to help it, please?
Oh, sounds really awful, doesn't it? Chemotherapy does come with so many side effects, and not everybody will have all of the side effects
Yes, yeah.
that we're talking about here. But when you do experience them, it can be really miserable. So it can often affect your gastric tract, so it can affect your stomach, it can it can give you diarrhea, it can give you constipation. And if you're really struggling with constipation, drinking a lot of fluid can help. So keeping hydrated, having a lot of water, high fibre diet, if you're able to keep it down. And some people, that's the last thing you feel like doing when you're feeling grotty, but trying to eat high fibre diet, prunes, pears, those sorts of things can help. Moving a little bit more than if you can, and again, when you're feeling grotty, it's the last thing you want to do, but movement and gentle exercise can help with that as well. But certainly, if the Luxido isn't helping, go back to your treatment team and ask them, because there are other laxatives that they can give you.
Yes.
And there are lots of different supportive medicines out there, so talking to them about what, that one's not working, what else can I try. But have a look on our website as well. We've got information about diet and things like that on our website, and side effects of chemotherapy that you might find useful. And just to say as well about chemotherapy, we do have a really good forum with chemotherapy threads on there. And a lot of people find that really helpful to sort of register with that and talk to other people that are going through chemotherapy at the same time. So it's worth having a look at.
And a couple of questions have come through about mastectomies. So Sophie has asked, she had a single mastectomy in March, which has healed fine. However, I had an axillary lymph node clearance 3 weeks ago, and the sensation and pain in her upper arm is consistently there. I've also got less mobility in my shoulder. I'm doing all of the exercises I've been given. I appreciate it was only 3 weeks ago, but is there a rough guide of how long this might last?
Oh, Sophie. Oh, that's tough, isn't it? So, so axillary node clearances, they can be actually sometimes more uncomfortable and take a longer recovery than a mastectomy. And that's because there's a lot of nerves that are in your armpit. So when you have surgery to your armpit, you do find that you can get an awful lot of different sensations. So you say the sensation in your arm is constantly there. You may find that changes. So sometimes it's pain, sometimes it can be numbness, sometimes it can be tingling. It will improve. It usually does improve, but it can take some time. And again, it's difficult to give you a timeline for that because everybody is different. If you're finding that your shoulder mobility isn't great and you're doing the exercises, it could be worth talking to your breast care nurse and seeing whether they can get you a referral to physio. And just trying to sort of, and talking about which exercises might be the best ones for you to do as well, because there's certainly, if you've got the leaflet that we have, that you probably have been given that one, the one where you're walking your arm up the wall, that can be a really good one for getting that movement going. And what I say to people quite often is, if you have a room with tiles, or you've got somewhere where you can put a pencil mark and see where you get up to on day one, and the next day just try to do it a little bit more, but don't try to go too much too quickly, because it's a gradual thing and it will get easier. And some people find that it's a lot easier to do those exercises after you've taken pain relief as well. So
Yeah,
if you've got pain
absolutely.
relief, try and do that first. But certainly go back to your team and ask about referral for physio if it's not improving.
Yeah. Yeah, and as Katie said, Sophie, don't overexert yourself. I think just take things at your own pace, and you will find that the more you use your arm, that it will slowly start to improve. And also have a look on our YouTube channel because there are some great demonstrations
There
of the
are, yeah.
exercises. So yeah, you can have a look at that. But yeah, definitely ask for a referral to the physio.
Yeah.
Okay, so a few other questions. Mandy has had a right mastectomy a year ago. Radiotherapy only finished last year November. She's currently on anastrozole. She gets really bad hot flushes day and night where her hair is dripping. She has tried taking it at different times. Any advice, please?
Mandy. So we touched on this earlier as well, didn't we, about the hot flushes with hormone therapy, and they can be really debilitating, and particularly if they're sort of affecting your sleep as well. So I mentioned earlier, and if you wanted to watch back the Facebook Live, you can do that. But things like wearing natural fibres, having a fan. Sometimes changing your diet a little bit can help as well. So some people find that they have specific foods and drinks that can trigger a hot flush. So spicy food can be one of them. Caffeine, unfortunately, can be one of them. Alcohol can sometimes be. So avoiding things that you know will trigger can sometimes help. If it's really causing you a lot of problems, and none of the things that are mentioned in our leaflet or our web pages are helping, then do go back to your treatment team and talk to them. They may suggest that you come off it for a short period of time to see if those symptoms improve. And if they do, they might suggest switching you to a different tablet. So letrozole might be another option to try. And as I said earlier, although those side effect profile on paper look very similar, some people do find that they get on much better with one than another. I know you said that you've tried taking it at different times of day, so that's obviously not going to work for you. But there are different options that you can try, and talk to your treatment team. They might be able to refer you, depending on where you are in the country. Some places have complementary therapies that they can refer you to as well, which can help as well.
Definitely. And Tracy has triple negative breast cancer, and she has asked, is there anything that she could take for hot flushes for people that have a triple negative breast cancer?
And that's a good question, Tracy, and it's something we get asked a lot because I think a lot of people think because it's triple negative cancer, it doesn't respond to hormones, and I'm wondering if this is where your question is coming from, whether or not they could take like hormone replacement therapies. And actually, the evidence isn't there to say that that's safe. So, really, the advice would be the same for anybody that's got a triple negative or a hormone positive cancer: is that to avoid any hormone supplements and any hormone tablets, and have a look at our website at the managing menopausal symptoms to see if there's anything there that will work for you. But yeah, it isn't any different advice for somebody that's got triple negative breast cancer.
So another question from Amina. She has metastatic breast cancer. It has spread to her bones. She's been on letrozole for 2 months. I know the cancer is in my lower and upper spine and right hip, and since starting the letrozole, I am in a lot of pain in those areas. Is that normal?
Okay, so so the pain that you're experiencing, Amina, it could be due to the letrozole, but it could also be due to the cancer. So it's really difficult to know what is causing that discomfort. If it's got worse since you've been taking the letrozole, I think you need to go back to your team and talk to them about that. And they might want to. I don't know when you last had a scan. But they might want to scan that. They might want to talk about if there's any other treatments that they could give you that maybe might be better for you if you're in a lot of pain, because we don't want you in a lot of pain. That's it's all about quality of life, and if that's causing you a lot of discomfort, it might be that they need to think about switching you to something else. So it's difficult to know is the answer whether that is the letrozole that's causing that, because we know that letrozole can cause joint pain, but also if you've got bony mets in the spine and hip, and that's where it's hurting, it could well be that it's that that's causing that as well. So talk to them about that and see whether there's any other treatments that they might be able to discuss with you.
Yeah, sometimes it's difficult to differentiate between the side effects and sort of the
It
symptoms
is, yeah.
of breast cancer. But yeah, absolutely go back to your treatment team and they can investigate that. Susan has asked, any advice for post-operative cording, please? So she is post-wide excision lumpectomy and lymph node removal.
Okay, so cording is a really common thing that can happen after you've had surgery, and particularly if you've had surgery to the lymph nodes, and that's when you can get what feels like a fibrous cord that runs down your arm. It can be feel quite restrictive, and it can feel as though you don't want to move your arm, that it might snap. A lot of people describe it as having like an elastic band running down their arm. Some people can physically see it as well. The best thing to do for that really is the exercises that you get when you should have been given those when you came out of the hospital for your post-op recovery. And if you do those exercises, and at the same time, if you can feel that cord, just gently massaging that at the same time, it can be quite uncomfortable to do that. So taking some analgesia beforehand can be helpful. If it's really persistent, it should eventually, that should settle down. And people are often very frightened to do their exercises because they think they're going to cause themselves more damage because that cording can snap, as people say sometimes. But actually, that's not going to cause any harm. It's only going to make it better. But it can be counterintuitive to do that sometimes. So if it's not improving and it's really restricting your movement and causing you a lot of discomfort, do talk to your breast care nurse as well, because they might be able to refer you for some physio for that.
Mandy has asked, she is going on holiday soon. She's really worried about the sun. Does she need to avoid it?
Okay, so you haven't said what treatment that you've had, Mandy. So if you've had radiotherapy, and we know that skin can be a lot more sensitive to the sun, so we'd always recommend that you keep yourself covered up and wear a high factor of sun cream. If you've had chemotherapy, you can also be a bit more sensitive to the sun from side effects from that as well. So I mean, general advice would be to wear a high factor. Any areas that have been irradiated to keep completely covered. And just to keep stay in the shade where you can, but have a lovely holiday. It sounds like you deserve it, and it's good to get out and get it. We don't want you staying in the dark and avoiding the sun altogether, because vitamin D is good for you, but it's just being cautious, as most people should be anyway when they're in the sun. So it's just wearing a high factor of sun protection, cotton clothing to keep out of the sun, and keep in the shade where you can.
Hope you have a good holiday, Mandy.
Yeah, have a lovely time. And actually, I think that's quite a nice place to finish. And take care, everybody. Have a lovely
Thank you for the
evening.
questions.
Thank you.